So,
Yes, sir, we are live. You can start the session.
a very good evening to all of you who have joined us here on this meeting for an awareness of lung cancer talk. And I am Dr. Gunjan Bejal. I am an radiation oncologist, an oncologist who specializes in use of radiation as a treatment for cancers, both curatively as well as for palliation of symptoms. So today, and I'm working in Manipal Hospital, Goa, as the head of the radiation oncology department there. So today we've gathered here to discuss on lung cancer. Basically, the month of November is Lung Cancer Awareness Month. And so we have decided to do this kind of a discourse for you all so that you can understand what are the challenges, what is the basically the footprint of lung cancer in our country and the challenges that it holds for people as patients and for us doctors and clinicians as far as the treatment and the diagnosis goes. So why is lung cancer so important that we need to dedicate a full month to its awareness? The reason for that is because if you consider the statistics worldwide, it is by and far the most common cancer and the leading cause of cancer death in the world. If you see in the United States of America, about 1 out of 14 people, 1 out of every 14 people have got a lung cancer, and 2.5 patients who die of cancer are those of lung cancers. In India, it is the 4th most common cancer as per the Globocon data of 2020. And in males, it is the 2nd most common cancer after the cancer of the oral cavity, the lips, the buccal mucosa, etc. Now, why is it so important that we think about it as a whole thing so that we educate you? Because currently, if we see the world statistics, only 19% of the patients survive 5 years or more after diagnosis. Very grim, very dismal. But the truth is that if you can detect this cancer in an early stage, that is stage 1 and stage 2, the 5-year survival rate is close to 60 to 70%, 50 to 70%. So what does this mean? Why are only 19% patients surviving? It is probably because most of the patients who are diagnosed in an extremely advanced or in a stage 4 disease, as a result of which we are not able to save as many patients as we want, and thus making the picture of cancer look very grim. In fact, one of the cancer survivors by the name of Sheryl Crow, if you know, she's a very famous singer and a very famous and a very, favorite singer of mine. I love the song Santa Monica Boulevard by her. She in fact said that more than 10 million Americans are living with cancer and they demonstrate the ever increasing possibility of living beyond cancer. And probably the way of living beyond cancer is to try and detect it early so that you can treat and cure as many patients as is possible. So was said by a very famous journalist, Mr. John Diamond, who also battled with throat cancer himself. He said that cancer is a word, not a sentence, not a death sentence, as many of us believe. So if we want to convert this death sentence into a simple word, which no longer bothers us, probably the way is to try and detect it early. So let us start this at the beginning as to what is lung cancer क्यों होता है, किसको होता है, who are the people who are more susceptible. Let us try and answer these simple questions. So if you see any cancer which affects the various organs is named by and large by the organ it affects. So lung cancer is one which is affecting the lungs. So what is it that causes this to happen? Now, cancer is an abnormal growth of cells. We all know that cells go berserk and they keep growing. Now, what stimulates them to grow is any mutation which happens in the genetic structure of the cell can lead it to grow berserk in a berserk manner without the cells normally dying and being removed from the body. So that is what leads to the cancer. Now, how do they go berserk? Very simple. 3 reasons can be there for it. 1, if you have done something that causes this mutation. 2, if the environment is full of something which is causing this mutation. Or 3, if there is a hereditary structure or is being transmitted along your family lines. So this is the simplest way I can explain what is lung cancer. So now, what are the types of lung cancer? So lung cancer can broadly be divided into two kind of types of cancer. One is a non-small cell and the other is the small cell. Of this, the non-small cell variety of cancer is very bothersome for us because out of 10 patients, almost 8 to 9 patients of lung cancer, out of 10 patients of lung cancer, 8 to 9 patients of lung cancer would be having non-small cell lung cancer, which would be a squamous cell carcinoma or an adenocarcinoma or an undifferentiated large cell type of carcinoma. So these are molecular subtypes of the cancer. Now, who does this cancer affect? So what are the risk factors? Now, the most common risk factor is tobacco use or smoking. It may be in the form of cigarettes, BDs, e-cigarettes, everything, all forms of tobacco which can be smoked can cause this lung cancer. So who does it affect more? Men, women? Probably today it is affecting men more, but the incidence in the Western world we see is increasing in the females as well. This increase in the female incidence is probably due to the more rampant use of tobacco by the women in the form of cigarettes, e-cigarettes, cigars, pipes, etc. That might be the reason. But yes, as of today, men are more affected. And as I have said, that it is the second most common cause of cancer in males, while in women, it is about 5th or 6th as far as the common things are concerned. So, in fact, smoking not only causes lung cancer, smoking can cause so many other cancers like that of the oral cavity, the esophagus, the food pipe, throat cancer, lung cancer, yes, the stomach cancer, bladder cancers, so many kidney tumors, so many tumors can be caused by AML, all can be caused by use of tobacco smoke. And in fact, it is so dangerous that if you look at the cancer deaths, almost 8 to 9 patients of cancer who are dying, out of 10 patients of cancer who are dying, 8 to 9 patients are smokers. Cigarette smoke has got almost 7,000 chemicals. Out of these 7,000, almost 70 chemicals are carcinogenic. So when you are smoking a cigarette, just imagine in one shot, you're inhaling 70 carcinogenic substances at one shot. That is the high risk of cigarettes causing cancer. Later on, we'll come to the concept of how much smoking is actually, is going to affect your lungs severely to cause cancer. But very, very importantly, you must understand that cigarette smoking in any form, even the minimalistic smoking, can increase or does increase your risk of getting lung cancer. Passive smoking, yes, passive smoking does definitely, not individually. If only risk factor is passive smoking, generally we do not see that patients have an increase in their cancer risk. But why one should be very aware of this? Because there are so many environmental pollutants which are also increasing your risk of lung cancer. So if at all you are inhaling passive smoke, and there are other risk factors like familial history, previous history of your having suffered from a malignancy, environmental exposure to so many carcinogens, then yes, that will increase the risk of causing a cancer. Amongst the environmental or occupational exposure is what I will call it more. There is the impact of a particular gas which arises from the soil and the rocks called the radon gas. I haven't seen too many patients with this exposure present to us in our countries. In the Western countries, yes, there is some amount of radon exposure which does cause lung cancers. Amongst our setting of the Indian setting of environmental or the occupational hazards, very important occupational hazards are in the form of asbestos, silica, smoke dust or coal smoke, diesel fumes, cadmium, chromium, beryllium, arsenic. These are the common industrial toxins which our work population is commonly inhaling and being exposed all the time, which may lead to the causation of cancer. And that is why we always advise these patients or these people who have these environmental exposures to limit their exposure. That is why they have necessary days, number of days off, number of days on from work, which is different for every industry. And their exposures are titrated, calculated, and only then they are allowed to work if the exposure is within the allowable limits. The other important causative factor for lung cancer is having had a previous cancer, which is now cured, which makes you more at risk of getting another cancer. Of note is the presence or is the treatment in a very young age for Hodgkin's lymphoma, especially in girls, which can give rise to a higher risk of breast cancer and lung cancer. But it is an extremely rare situation. It doesn't happen for every patient. In fact, it will happen for 1 in maybe 1,000, 10,000 patients. It doesn't happen in every, it's a very small risk. Of more importance is seeing your family history, your family lineage, whether an immediate relative of yours or a first degree relative of yours or two first degree relative of yours gets a cancer, then you are definitely more predisposed to getting the cancer. So again, so if you have a genetic predisposition, then we need to have a full genetic history charting in the form of a pedigree as to which degree of relative of yours was affected by cancer, how much was the lineage transmission, and then if we find any specific history, we can test for certain mutations to see if those mutations are there, and then we can advise you for if you are at high risk for screening of the lung cancer. Genetic cancers as part of the whole gamut of the cancers form only 5% of our diagnosis. Rest of the 95% of our cancers are mostly sporadic, but we are slowly seeing an increase in this also to see this. The other important thing is if you are suffering from some lung diseases like chronic obstructive pulmonary diseases, then you may be more predisposed to cancer, lung cancer. So these are the various different, risk factors that one should look at to see if you can develop a lung cancer or not. Now, once you have assessed your risk, one must know what are the symptoms which would probably make you think that you might have a lung cancer. First of all, before I start this part, I must tell you, most of the symptoms of a lung cancer are those which are part of other commoner disease presentations, like simple flu, cold, cough, tuberculosis, infection, pneumonia. All these things are more common. So one has to be very careful when one is trying to use symptoms as a diagnosis. And I'll come later why that is also not so much very important for you, right? So the symptoms are, if you have a cough that is not going away, 20 days, 30 days, it has been persistent, You haven't been able, you have shown a doctor. It is not that you have had a cough and it is persisting. So if it is persisting, it is a lung cancer. No, you've shown a doctor. Doctor has tried to investigate, tried to find out other causes, is not being able to find out any other cause. Then one must suspect, is it a lung cancer, and try and investigate it in that line. If there is blood on the sputum or mucus, it is a very common symptom of tuberculosis as well. But as tuberculosis is on the decline, blood in the sputum, one must definitely get suspicious, and one must definitely see if it is due to a malignancy. If you are getting an unusual pain in the chest, which is lingering for very long, not going away with anything, you've tried to rule out cardiac disease. If there is no cardiac event, then definitely maybe it might be advisable to get yourself investigated with a CT scan or something like that, and see if there might be a lung cancer there. Breathlessness, of course, everyone knows if the lungs get affected to a large extent, then definitely there is eventually going to be the onset of breathlessness, or wheezing will slowly settle in once the lung cancer starts to obstruct the respiratory passages. Of course, because of all these symptoms and the metabolic demand of the cancer itself, you will start to feel tiredness. Difficulty in swallowing might be a presentation if the lung cancer is located centrally in the chest, has involved what some structures called the lymph nodes that are there in the mediastinum, which are pressing on your food pipe, which may give rise to symptoms like difficulty in swallowing, hoarseness of voice, if your voice has suddenly started to become hoarse, weight loss, that is important, bone pains, neurological symptoms. So these last few symptoms which I told you, dysphagia or difficulty in swallowing, hoarseness of voice, up to the neurological symptoms, these are now symptoms of an extremely advanced lung cancer. However, even if these symptoms are there, you must try and investigate and see what it is. So what is very important is, even though symptoms are there, the very, very important point here, which is underlined in red, blue, and green, is that once the onset of symptoms happens, it is very likely, if we try to investigate, we are very likely going to find something which is advanced in nature. That is why when we say initially, remember I told you 5-year survival is about 19%. That is because we are diagnosing very late. Patients are coming to us very late. That is why we are getting this kind of a survival. What is the idea? The idea is to try and detect these tumors in an early stage, even before the onset of symptom happens. If we can do that, only then we will be able to catch localized tumors, small tumors in the lung. So this is what is screening. Screening means trying to detect before the onset of symptoms, trying to detect at an early stage. And what is important about screening is that you must screen the population who requires to be screened. Today, when we sit in our clinical practice, very often someone would walk in and say, I want to get a CT scan done because I think I have got a lung cancer. No, that is not correct. Screening is a way of diagnosis, or a way of diagnosis which has to be, some steps have to be followed. First, your risk has to be assessed, whether there is high enough risk for you to be screened. If yes, screening doesn't mean that one day you walk into a chamber, you get a CT scan done and then disappear. No, your screening should be a continuous process. That is, we recommend for those patients who are high risk, they be screened on an annual basis. So who are these high risk patients? These high risk patients would be anybody, male or female, who is 50 years of age or more. 55 to 70, that is the highest risk bracket, but we take it as 50 years or more. That is one criteria. Second criteria which must be met is that you have a history of smoking greater than 20 to 30 pack years of tobacco smoke. What do you mean by 20 to 30 pack years? This is what we will discuss right after this next point. Anyone with this kind of a smoking history who has quit but less than 14 years is at high risk. So you have to be screened. Anyone with this kind of a history who is a current smoker or is continuing to smoke is at high risk and should be screened. Or apart from this, has some other important risk factor. Like I said, first degree relative who has had, especially at a young age, who has had a lung cancer at a young age, that is a high risk factor. More than 2 first degree relatives having a lung cancer, that is a person at higher risk that we would definitely acknowledge as screening. Someone who has environmental or occupational hazard, we would consider at high risk and we would screen. So now let us define this. As I said, 20 to 30 pack years. What does this mean? So basically this 20 to 30 pack years. So let us take a simple example, 10 pack years. What would this mean? It would mean 1 pack of cigarettes for 10 years. 1 pack of cigarette here in this terminology means a packet of cigarette which has got 20 cigarette sticks in them. So 20 cigarette sticks in 1 packet, and 1 packet for 10 years is 10 pack years. Or if you are smoking half a packet or 10 cigarettes, so half a pack for 20 years, that would be 10 pack years. So like this, 20 to 30 pack years, if that is your smoking history, then you are definitely at risk, at high risk. Now, mind you, when I say this, what I am saying is that these patients are extremely high risk. But those patients who are smoking less than this doesn't mean that you will not get lung cancer. You can get. In fact, smoking has got many more disadvantages. It is a cause of cardiac morbidity. It is a cause of cancer-related morbidity, and it can cause so many other diseases as well. So smoking in all its sense actually is not a very good habit to have. So if you are having the habit, it is better to give it up as soon as possible. Because if not a cancer, it will affect you in some other negative way or the other. So now, having defined this subset of patients who are at high risk, how do we screen these patients? Do we do an X-ray? X-ray is not a good tool for screening. Why? For screening lung cancer. Why is X-ray not a good tool for screening? Because by the time a tumor is visible on a chest X-ray, the tumor size is already very large, which means that the idea of trying to detect a small tumor will not be subserved by chest X-ray for a large battery of patients. So what is the right method of screening? The right method of screening would be to do a low dose CT scan. A low dose CT scan is slightly different from a normal CT scan. It delivers a much lesser dose than of a radiation to a patient than a routine CT scan. So it minimizes your exposure. And because of this slight exposure is there, we do not recommend to everybody to go for a screening. We recommend only the high risk patients to go for this kind of screening. And with this low dose CT scan, what are we trying to detect? We are trying to detect nodules. You may get several types of nodules, which may mimic other diseases as well. But the highest chance of lung cancer comes in nodules, which on the CT scan are solid in nature, that is one character, or partially solid and partially not solid. We call them non-solid nodules. So these are the two nodules which are at high risk. Another feature which might tell us, which might suggest if the tumor is slightly larger, is speculations. If we see hazy edges on the tumor, which are like spikes as you see on the cycle tire, then you might think that this might be a malignancy. And once if you detect such a thing, then definitely immediately you have to go in for further testing to try and rule out. If, however, we detect something which is not suspicious, then based on the history, we may recommend this scan to be done on a slightly lower interval. Like if you have a nodule which is say less than 1 centimeter, it is there. We may ask you to do the low dose CT scan after 6 months or 3 months. However, if the nodule is larger in size, say 1.5 centimeters, then we may ask you to go in for further investigations like a biopsy or a bronchoscopy or a PET CT to find out what is the malignant potential of this particular tumor and how we should go ahead with treating it. So this is one thing that is important. Then secondly, very often we find the biggest challenge why we detect these tumors late is because very often patients feel that going in for these low dose CT scans on a yearly basis, especially if you're high risk, is somewhat going to cost money and other things. The financial aspect comes in. But what one patient needs to understand is that the low dose CT scan only costs maybe 1,000, 2,000, 3,000 at the max. Vis-a-vis, if your tumor is detected in an early stage, you would be required to take lesser treatment than when it is detected at an advanced stage, where you would have to take much more treatment. In an early stage, the possibility that your boat will sail home and you will be safe, secure, and probably cured is a higher chance than when you are detecting the tumor in a relatively advanced stage. So these are the things you need to understand, that why screening is helping you. Screening is helping you make your quality of life better by lesser amount of treatment, by longer duration of disease-free life. It is improving the chances of your survival. It is by lesser amount of treatment means lesser number of side effects. So you are able to spend more quality time with your family. And lesser amount of treatment means lesser cost. If you look at some of the numbers that are flung around in the commercial circles with regards to the amount of spending in cancer, it is huge. Only if we detect these things early, you will find that this spending will come automatically, because the number of treatments needed to be administered to these patients in early stage would become less. So that is a very, very big advantage of this one. The second reason why patients don't come is anxiety. Is anxiety that if I do a CT scan and something is found, then what? If you don't do a CT scan and that thing which is there increases in size, and then when you get a big symptom, you come and you find that it is not curable, nothing can be done much about it, and you are on palliative therapy, palliative immunotherapy, what is the point? You tell me, isn't it more better not to have that anxiety of the fear of detection of something? If something is there, it is there. It will be detected. At the end of the day, we need to move and we need to find it as fast as possible and do the needful for the best possible outcomes. So this anxiety can only be allayed provided this kind of an education happens with the patients, and one fends for the other, one motivates the other to get things done at an early stage, rather than discouraging people from going in for early detection, tests, diagnostic aids, and other things like that. So that is very, very important. Yes, any screening modality has a challenge. The biggest challenge is false positives. That is, if you do not have a malignancy, there is a nodule. As I said, nodules can be due to other diseases as well. So you see a nodule and you think that it might be malignant, but when you investigate, you find it is not malignant. So even that is a good thing, isn't it? At least you came to know what you have. You may diagnose tuberculosis by virtue of this, and you may take simple treatment and be cured of it. So once something is detected, you must make sure that you follow the treatment till the end so that you get the best possible outcome from screening. Screening is done so that we can find out these tumors in an early stage and give you the best possible outcomes from your disease. So once you have screened, now it may so happen that you have a nodule. Then what? Now comes the time whereby we are trying to detect, we have detected a nodule. Now we are trying to detect if it is a cancer. So what are we going to do for that? Simple tests are biopsy, which can be done is the needle biopsy on a CT scanner, CT scan guided biopsy, or we could do a bronchoscopic biopsy, or sometimes if it is very small and very accessible, we can do a video assisted thoracoscopic surgical biopsy of the tumor. And then once we get the character of the tumor with the biopsy, we may want to do a PET CT or bone scan and CT scan to stage the tumor as to what is the stage 1, 2, 3, and 4. 1 and 2 being the earliest stage, 3 being locally advanced. The end of stage 2 and the stage 3 diseases where the tumor has now started to spread to the lymph nodes in the hilum, that is the beginning of the mediastinum or the lungs, and to the mediastinum, that is the stage 2 and 3 subgroup, end of stage 2, 2B and 3AB. And 4 is when it has spread to other organs like bone, liver, brain, and other areas of the lungs. So once your staging is complete, what are the treatments? In the early stages of disease, that is in stage 1 and early stage 2, the mainstay of treatment would be surgical extirpation and, if required, followed with some few cycles of chemotherapy based on what we see on the surgical specimen or on the PET CT. Now, very many times, patients who present even with the early stage cancer do not have a good lung function. Why? Because they've been smoking for a very long time. So their lung functions are not good. They are not in a medical condition to undergo a surgery like a lobectomy in which the full lobe of the lung is removed, or a pneumonectomy in which the full lung is removed, or a wedge or sleeve resection which a small part or sleeve of the lung is removed. So they may not be medically fit for that. They may have other comorbidities like a cardiac comorbidity, previous myocardial infarction, heart failure, due to which their hearts are not functioning well. Now, what does this mean? If surgery is not done, is that the end of the story? No. In fact, the newer advances in treatment have led us into believing and into research showing that for those patients who cannot be operated, radiation by newer techniques called stereotactic ablative body radiotherapy or stereotactic body radiotherapy can be given in high doses precisely around the tumor, limiting the dose of the radiation to just around the tumor with minimal margins and a high dose per sitting, which lasts for about 1 to 5 sittings of radiation, and we can ablate the full tumor in 50 to 60% of the patients. So this is a very, very, I won't say very new, but yeah, a very new advance in radiation therapy technology, which makes radiation the mainstay around those patients who cannot be surgically operated or do not want to be surgically operated. They can be given a good chance of cure with this radiation with minimum side effects and maximum possibility of cure. Now, when we come to the slightly locally advanced group where the lymph nodes in the mediastinum have been involved, in these particular patients, the mainstay of treatment would be the assessment for a chemoradiotherapy, that is radiation together with small doses of chemotherapy to sensitize the effects of radiation. That would be one option. And the other option would be to downsize the tumor with the use of chemotherapy and then subsequently go in for either radiation therapy or surgery for these patients. However, if the patient is in stage 4, then the challenge is that these patients are not exactly candidates for cure. Sorry, I forgot one important thing is that in these stage 2 and 3 patients, nowadays there is a newer drug which is coming into picture, which is called the anti-PD-L1 drug called durvalumab, which we are very often using after curative radiotherapy in order to maintain the response for a longer time, and we are seeing better survivals for these patients as well. Now, if you are diagnosed in the stage 4, well, don't lose heart. Yes, it is not exactly a curable situation, but not being curable does not mean that you cannot have a decent life for as long as you live. These tumors are treated with the mainstay of chemotherapy, and very often while doing the biopsy, we can send the biopsy specimen to detect some molecular markers or some genomic sequences whereby we detect certain gene sequences if present in the tumor. Then we can give some directed or targeted therapies or immunotherapies to these patients based on the kind of mutation that we detect. For example, if we detect an EGFR mutation, nowadays very often we may give the patient something like an erlotinib or an osimertinib, which is directed only specifically for these mutations. Currently, the status of these immunotherapies is such that they are more beneficial for patients in the 4th stage of malignancy. These are palliative treatments, but eventually end up increasing the life, whereby the 2-year survival now for these particular patients is almost up to 30 to 50% with the use of these kind of treatments. Along with these treatments, we would intersperse the use of radiation therapy for symptoms like if there is a spread in the bone, patient is having bone pain or an impending fracture, radiation can be given to those localized sites to try and improve the quality of life and reduce the symptoms. Sometimes if there are very few sites of metastasis, then we can also use the said modality, as I said earlier, the stereotactic ablative body radiotherapy, to try and ablate the tumors in those local areas to give you longer pain-free and longer duration of healthy life. So this is what is about the basics of the treatments. These treatments depend on a lot of things and are very complex. It's not possible for me to cover it in such a short time. But eventually, if you want to prevent the lung cancer, the surest and the most certain way and the largest amount of prevention that will happen is by the giving up of smoking. If you can give up tobacco, then definitely, yes, you can definitely reduce the risks of you're getting a cancer. So if any one of you listening on to this is interested in giving up smoking, the type of medical professionals, any oncologist will help you definitely in giving up smoking, and a psychiatrist or a psychologist is definitely qualified into speaking to you, to telling you about the use of nicotine patches or nicotine gum, depending on the amount of smoking habit you have. You could also do some kind of formative therapies along with these patches, because one of the things which happens with smoking is, when you are smoking, you hold the cigarette between the 2 fingers, and the habit becomes of bringing the 2 fingers to the lips. So to give up that habit, very often we tell them that, okay, now you're not smoking, but to give up that habit, you have to chew on to badams. And there is a national helpline for smoking. The number is 1-800-112-356. So in case anyone wants to start giving up smoking, then now is the time. Today is the time. because as Stuart Scott, another cancer fighter, has said, he's a sports center journalist, you can beat cancer by how you live, why you live, and the manner in which you live. Thank you. So let's try and detect all the cancers early and cure as many as possible. Thank you so much for the attention. Now I'll just take a look at some of the questions which have been sent to me. So here there are quite a few questions I can see. Who are more likely to develop lung cancer, men or women? Okay, so as of statistically, men get more lung cancer, but women are also getting lung cancer, as I have said, because of the more use of tobacco. Now, having said that, I don't mean to say that women should stop going out and having a good time. No, but it would be better if they do not indulge in the habit of tobacco use. That is definitely going to reduce the malignancies in both the genders. Is treatment same for, yeah, is treatment same or different for men and women? Now, as I said, it is more or less dependent on the stage and the kind of malignancy that you get, and the kind of molecular markers that are expressed. So yes, provided the man and the woman has the same stage, the same molecular markers, we will use the similar kind of treatment. Looking at the increasing pollution levels, what are the chances of developing lung cancer due to air pollution? So again, now you have to look at it objectively. Air pollution is a very wide and vast subject. So as I said, one of the causative amongst the environmental things is asbestos, beryllium, cadmium, diesel smoke, silica, coal smoke, diesel fumes. So these are some of the carcinogens. Now, carcinogenesis doesn't happen by taking a single whiff of a diesel fume. It is a continuous exposure which is required for that. And yes, so you need to assess what are the carcinogens that are present in the air. If any of the toxins or carcinogens that are present in the air, which is polluted, air can be polluted by particulate matter, but particulate matter eventually will not lead to Ca. It has to be carcinogenic particulate matter. So yes, definitely with air pollution, you are likely to find, if there is a lot of industrial effluents, then you are likely to find that if you find any carcinogen in the air, definitely yes, that can lead to chances of lung cancer. But yes, you need to be sure what we are seeing before incriminating something. That is definitely a must. You should not incriminate just like that, saying ki, okay, there is one, what should I say? There's a khadi udyog behind my house, so there is going to be lung cancer. No, that is not going to happen. And even if that is there, there are certain guidelines. You need to see if those guidelines are being followed by the industry, and the air pollution which you are talking about is within the tolerable limits. Then we cannot incriminate that particular industry for a carcinogenic this thing. What are the chances of a non-smoker developing lung cancer if genetically predisposed? As I said, 5% of our cancers are genetic cancers. The risk is there. You need to see what genetic predisposition is there. Based on the genetic predisposition, it may not only be a lung cancer, it may be other cancers like a prostate CA, a pancreatic CA, or other things. So we need to see what is that genetic predisposition, and based on that, we can devise a strategy for screening for all the necessary cancers for this particular person. So these last two questions, in fact, quite good questions, and in fact very burning questions which patients often ask, and we have to do quite a bit of testing for these patients to eventually reach to the bottom of their of the mystery of what we should exactly do for them. So yes, that is one thing. What precautions should a person take if an immediate family member has had lung cancer? Okay, if person's immediate family member has had lung cancer, you must see if that person had a lung cancer, was a smoker. If yes, probably that is a smoking related cancer, and probably what you need to do is don't smoke. So that is the simplest precaution that you can take if that person who had a cancer was a smoking cancer. However, if the person has had lung cancer at a very young age, then yes, probably you need to check up with your local oncologist and see if there are any high risk features for you. Disclose your history to him with regards to your habits, and then see if at all you need to do a screening. If you need to do a screening, your oncologist will advise you as to when and how you should do, and whether you should go on to a annual screening program. So this is also an interesting question. Yes, so this one I think I've answered. The last one, at what age should one start screening himself or herself? Not everybody. Not everybody. Only if you are at a high risk of screening, as I said, greater than 50 years, a history of smoking of 20 to 30 pack years should be there. If you have any other risk factors, these are the things you should look at. And only if you have these risk factors, you should start screening yourself. You should not go and just screen yourself, because even doing a low dose CT annually poses a small risk if you are not amongst the really high risk people. So you don't want to increase your risk by doing something which you wouldn't have done. So I think these are all the questions that I have got for this session. So I will now bid you a good night, and thank you so much for your patient listening. I hope all of you, those of you listening who have a habit of smoking, will today take up the project of giving up smoking and do your best to see if you can help somebody detect this cancer early and treat it to the best of the medical capabilities. Thank you and good night.